Hi engineers, in this video we are going to talk about the treatment of heart failure. A lot of things to go over. Let's go ahead and dig into it. Hi engineers, so when we talk about the treatment of heart failure, before we start really diving into that, I want to take a quick look, very quick, at the diagnostics of heart failure. If you guys remember in the video where we talk about the pathophysiology, we talk about the compensation mechanisms, we talk about the symptomatology of heart failure. It's primarily a clinical diagnosis you based upon their symptoms. If you really want to, and they maybe are having like an acute exacerbation, they're decompensating, and you want to figure out the underlying cause or the reason why they're having this heart failure, you can order other tests. For example, one of the things that are commonly done for people with heart failure is they get a chest x-ray. What's a chest x-ray going to show? It could show a big heart, cardiomegaly. What's the second thing it could show? It could show that if the left heart is failing, fluid is backing up into the pulmonary circulation. What's that called? Pulmonary edema. And sometimes it can even show fluid in the pleural cavity. Sometimes people with heart failure can get what's called bilateral pleural effusions. That's one thing you can get from heart failure. But again, it doesn't completely diagnose it. It's just something that you can look at based on their symptoms. What's another thing you can do? Another thing, and we'll talk about it in the mechanisms here, is another one is called BMP, brain natriuretic peptide. It's made by the ventricles when they're under extreme stress. So when a person has heart failure, their muscle is under extreme stress all the time. So the level of BNP or BNP with brain natriuretic peptide can also help in some way, shape, or form to determine the likelihood of CHF. It's not diagnostic, it determines the likelihood of CHF. It's more commonly used to determine the effectiveness of treatment. We'll explain that a little bit later. Another thing you could do, pretty much the gold standard if you really want to determine heart failure, is an echo. An echocardiogram is going to tell you a couple things. It's going to tell you whether the heart's basically dilated, the ventricles are dilated, systolic heart failure. It's going to tell you if they're really stiff and they don't want to relax during diastole, diastolic heart failure, or it might tell you that they have a wall motion abnormality. It's not contracting right. Maybe they have an MI. Maybe they have cardiomyopathy. Maybe they have a valvular heart disease. But you get the point. Heart failure is primary clinical diagnosis. If you really want to, I'll write down these things. Other diagnostic clues for heart failure, if you really want to remember, is chest x-ray. Okay, that's one. Second thing, if you really want to remember, is you can measure the BMP levels. The BMP levels are super elevated. Depending upon if they have heart failure, it might be greater than what's called 400 picograms per milliliter. You don't really need to know that though. Okay. Third thing is it might also be something like an echocardiogram. This might determine whether somebody has, again, systolic, diastolic, or some other type of pathology going on. Okay? If you really want to, another cause, if you guys remember all the causes of heart disease, is sometimes ischemic heart disease, like a myocardial infarction. So sometimes doing what's called a cardiac catheterization can also be done to determine maybe the underlying etiology of heart failure. But again, primarily clinical diagnosis. Okay, now treating heart failure. When we treat heart failure, we treat it based upon the severity of the patient. The New York Heart Association developed this class or grade system. So again, New York Heart Association developed a 4-class system. Class 1 says that the patient is having heart failure, right? But their shortness of breath or their chest pain that they experience is only with extreme exertion. So again, with extreme exertion, the patient develops signs of shortness of breath or chest pain. Moderate exertion, you guys get where I'm going here already. Exertion, they develop shortness of breath or chest pain. Mild exertion, they develop shortness of breath or chest pain. And if it's at rest, that's class 4, that's the most severe. Whenever they have shortness of breath or chest pain at rest, that's another thing that can tell us. Now, when we treat patients, we give them medications to treat their heart failure. We do it based upon the class system. And we'll go over each one and I'll mark what class they're primarily in. One thing I want you to remember though, is regardless of what their class is, you have to treat the underlying disease. If the patient has diabetes, insulin or diabetic medications or lifestyle management. If they have hypertension, put them on antihypertensive medications. If they have hyperlipidemia, put them on statins. If they have an MI, cardiac cath or cabbage if it's really that bad, right? So you get the point. It's trying to be able to minimize the risk factors. If they have obstructive sleep apnea, put them on CPAP. If they're obese, have them lose weight. Reduce the risk factors, treat the underlying disease, and you're going to help the patient out overall, regardless of what their class is. Second thing, these people hold tons of fluid in their body. You want to restrict their sodium intake because sodium holds on to water. So you restrict salt intake and you restrict water intake, particularly 2 grams of sodium per day, less than that, or less than 2 liters of water per day. So no matter what, treat the underlying disease, lifestyle changes, and also restrict water and sodium to less than 2 liters of water, less than 2 grams of sodium per day. Now, first thing we need to do before we start talking about each drug class is briefly go over the renin-angiotensin-aldosterone ADH axis. If you guys remember, what did we say was the stimulus for renin? It's basically low perfusion, right? So if there's decreased perfusion to the kidneys, if you guys remember, what does that do to the JG cells? So you have JG cells in the kidney that respond to that decreased perfusion or blood volume. That triggers the JG cells to release an enzyme called renin. Now, if you guys remember, the liver also makes a protein called angiotensinogen. And what renin does is he cleaves the angiotensinogen into another molecule called angiotensin 1. Now, there's an enzyme in the capillary endothelium of the pulmonary vasculature. And this enzyme is called angiotensin converting enzyme, commonly referred to as ACE. What this enzyme does is it stimulates the conversion of angiotensin 1 into angiotensin 2. What does angiotensin 2 do? He does a ton of stuff, man. This guy is a troublemaker. One of the first things that he does is he binds onto these receptors on your arterioles and induces vasoconstriction. Now, go back to some of the physiology lectures that we've done. What does vasoconstriction do? If you increase the vasoconstrictive mechanisms, you're decreasing the diameter of that lumen. If you decrease the diameter of the lumen, you increase the resistance of blood moving from this direction to this direction, right? That's called an increase in the total peripheral resistance. Remember the formula? Blood pressure is equal to cardiac output times peripheral resistance. If you increase this, what else do you increase? BP. Now remember, why is all of this stuff happening? It's because if you guys go back and think for a second, if we come back up here to the top, what was causing this decreased perfusion? A failing heart, right? So if you go back to this whole thought here, when a person had a failing heart, right? So their heart is basically kaput, it's not working, it's decreasing its cardiac output. And that decreased cardiac output is leading to decreased perfusion to your tissues. Your body's trying to compensate for that by increasing the blood pressure because we're trying to increase perfusion to the tissues. But it's making it worse. Why? Here's another thing. Let's come back here. If you increase the total peripheral resistance of the arterioles, what does that do to your afterload? It increases the afterload. And if you guys remember, what's afterload? It's the amount of pressure that your ventricles have to overcome in order to push blood into them, into the aorta, right? So for example, if I have here the heart, if I have an increased afterload, the pressure inside of the aorta is really, really high. My ventricles are gonna have to work hard and they're already weak. That's not gonna help them, okay? What else does angiotensin 2 do? He also stimulates your anterior pituitary. So you know you have your anterior pituitary within your central nervous system, right? So here we're going to draw, and again, this is not what you think it is. That's the pituitary gland. It stimulates the pituitary gland to make a hormone called ADH, and specifically is the posterior pituitary. ADH comes down to the kidneys, and what it does is it works in the kidneys by decreasing the urine output. So it decreases urine output and specifically increases water reabsorption If I increase water reabsorption, I increase blood volume, and technically I increase blood pressure. But here's the other issue with this. I increase blood volume, I increase technically the amount of blood that's going to my ventricles, which is called my EDV. And when you increase EDV, you also increase preload. Why is that a problem? The heart's already weak. You're putting more blood into a weak ventricle. If it has more and more blood, it's not going to be able to continue to keep pumping out the volume that we want. That's putting more stress on the heart. The next thing angiotensin II also does is he also acts on your adrenal gland and tells your adrenal gland to make another hormone, which is called aldosterone. And if you guys remember, aldosterone acts on the kidneys. And what it does is it actually increases sodium and water reabsorption. If you increase sodium and water reabsorption, you increase blood volume, which is designed to increase blood pressure, which is the whole issue here. But what else is it doing? It's increasing my EDV, increasing my preload, and what is that doing to the heart? It's stressing the heart even more. So you guys can understand now how all of this stuff works. Guess what drugs are going to do? They're going to prevent all of this. Let's go over which one. The best drug that you start off in a class 1. So this is the best one that you want to start in class 1 patients with heart failure is ACE inhibitors. Okay? So ACE inhibitors are angiotensin converting enzyme inhibitors. What are some of these drugs? Captopril, enalapril, lisinopril, and even another one called benzapril. Okay, so benzapril. All right, so you got all these different medications. What are they doing? Well, if you guys remember, they're doing what? They're inhibiting this enzyme. So if I come over here, I'm inhibiting this enzyme. If I inhibit this enzyme, I inhibit angiotensin II. I decrease the total peripheral resistance. I decrease the afterload. I decrease the stress on the heart. If I decrease angiotensin II, I decrease ADH release, and I decrease significant water reabsorption, increase blood volume, and increase preload. Less stress on the heart. If I decrease angiotensin II, I decrease aldosterone production, I decrease sodium and water reabsorption, decrease the EDV, and decrease the preload on the heart, and again, decreasing that excessive stress on the heart. That's why these drugs are one of the best ones. Other drugs that you can also use if you can't tolerate ACE inhibitors. In other words, one of the common symptoms that people can experience is a dry cough, or another one called angioedema. And if that's the case, we don't really want to put people on ACE inhibitors. So we'll try another drug. Another drug that's commonly utilized, or class, is called angiotensin II receptor blockers. We commonly abbreviate these as ARBs. Okay? Angiotensin II receptor blockers. Some of the big ones that are used are losartan, valsartan, and another one called candesartan. Okay, obviously losartan and valsartan are the more commonly utilized ones that you'll see. What are these drugs doing? They're inhibiting angiotensin II everywhere that it binds. So if I inhibit angiotensin II, I'm going to do the same thing that the ACE inhibitors do. Decrease the ADH, decrease the preload, and decrease the total peripheral resistance, decreasing the afterload and the stress on the heart. It makes so much sense, guys. Again, this is a class 1 drug. Okay, so class 1s so far that we've established are going to be ACE inhibitors. If you can't tolerate an ACE inhibitor, ARB. Next drug that's also utilized, it's more of a class 3 drug, and we use this in patients who have had myocardial infarctions and we're trying to decrease the remodeling of the heart, are called aldosterone antagonists. And these drugs are going to be things like spironolactone, and another one which is called eplerenone. Now, we use these, again, what are the reasons why we would use this? We use this as a class 3. So again, this is a class 3 drug. So in other words, basically with mild exertion, they develop shortness of breath and chest pain. you'll add this one on. The benefit of this drug is two things. One is it decreases the remodeling of the heart, which is important. You don't want a lot of fibrosis of the heart after it's had a myocardial infarction. That's one of the benefits. And the other one is it's potassium sparing. So if someone is already having hypokalemia with their condition, you can spare some of the potassium with this drug. What does it do? It's pretty simple to realize what it does, guys, right? It's going to inhibit aldosterone's action. If you decrease aldosterone's production, you decrease sodium water reabsorption, decrease EDV, decrease the preload, decrease the stress on the heart. Overall effect, decrease ventricular myocardium remodeling, and potassium sparing diuretic. Beautiful thing, right? The next drug class that I want you guys to think about, really this is also more of a class 3 drug. You don't really dip into this one until it's like, the patient is having all these other medications not working, and then you'll try this drug. There is some evidence that says that it has been able to decrease mortality and morbidity in patients with heart failure. Again, there's not tons of evidence on it. They did have a couple trials on it, I think actually 2 trials on this drug, and it's called Entresto. Before I do the drug, I just want to briefly explain what it does. Remember I told you whenever someone has heart failure, the stress on the myocardium. That stress on the myocardium causes it to release a specific chemical called brain natriuretic peptide, BNP. BNP does what? It's pretty simple, actually. It opposes all of the actions of angiotensin II. That's cool. If I block angiotensin II, what do? I decrease the vasoconstriction, I decrease the total peripheral resistance, I decrease the afterload and the stress on the heart. Okay, that's going to help the already pre-existing stress. I'm also going to block its effect on stimulating aldosterone. If I drop aldosterone and drop ADH, I pretty much combined decrease the water volume in the blood, decrease the sodium volume in the blood, I decrease my EDV, I decrease my preload, and I decrease the pre-existing stress on the heart. Well, that's a benefit as well. So this is actually a pretty good drug. Problem is though, there's an enzyme that breaks him down. And this enzyme is called neprilysin. Neprilysin. And what this drug does is he breaks the BNP down. So if we give a drug, which is BNP, yeah, it's going to have some effect, but we need something that's actually going to inhibit this thing right here to increase the BNP concentration. And we can also increase its activity by adding another drug as well. So here's what we do. We give a neprilysin inhibitor. We're going to give a specific type, and that's called sacubitril. Okay, so we'll write down here. One drug is called sacubitril. Sacubitril. Another one is called, you have another thing called nazirtide, but we're not going to worry about that. Sacubitril is going to be the neprilysin inhibitor. Okay, so here, we'll put down here, neprilysin inhibitor. But we're going to add on another drug to even enhance this effect. Another drug that we add is an ARB. So this is common to give what's called sacubitril and another drug called valsartan. Okay? When I give these two together, the drug that they give the name is called Entresto. So sometimes you might hear this, and what it's designed to do is have 2 effects. One is this drug is going to inhibit the neprilysin. Okay, so it's a neprilysin inhibitor, increasing the BNP concentrations to enhance this effect. But also, let's even enhance it even more and give valsartan. So now we're going to drop the angiotensin II activity even more. Can you imagine now how much more effective that's going to be? Because in people with heart failure, this system is super jacked up. So if we inhibit angiotensin II with this drug and increase the BNP to counteract the angiotensin II, that's a beautiful drug. So again, this is something that they use, and it has been shown in 2 trials, one of the trials specifically, to decrease the mortality and morbidity in patients with severe heart failure. All right, that's the drugs that I want to talk about relative to renin-angiotensin-aldosterone axis. Now what we're going to do is we're going to transition into other drugs that affect the sympathetic nervous system. All right, so the next thing we're going to do with this heart failure treatment is talk about the sympathetic effect on how heart failure is involved. Because remember, heart failure ramps up 2 systems, renin-angiotensin-aldosterone ADH axis and the sympathetic nervous system, to compensate for the decreased perfusion or the decreased cardiac output. So if you go back, remember, we said that whenever there is decreased cardiac output. What does that do? It stimulates specific receptors. Remember you have your carotid system, right? You have those specific nice little beautiful receptors here in the carotid sinus and the aortic sinus. And whenever they're stimulated by decreased blood flow, what do? They activate your sympathetic nervous system. Your sympathetic nervous system responds to this in a couple of different ways. One of the ways here is it's going to try to increase your heart rate. So it has these fibers here that come out and try to release norepinephrine onto the beta-1 receptors on the SA node and the beta-1 receptors on the contractile myocardium. Remember the effect of this. If you increase the release of norepinephrine and increase the heart rate, what does that do? You increase heart rate, that increases the what? Cardiac output, and that increases the blood pressure. But what else does it do to the patient, unfortunately? You increase the heart rate, you don't give the ventricles a proper amount of time to really relax and also to contract and eject enough blood out. And again, so whenever someone is having a tachy rate, maybe they're tachy, okay, in other words, you're trying to increase the heart rate, you're not giving the ventricles enough time to really get their blood flow, get their oxygen. And so that's stressing them. So again, as you increase the heart rate, you decrease the oxygen delivery to the myocardium. Because remember, when does the myocardium get its oxygen supply? During diastole. Well, if you're tacking away here, your diastolic period is going to be a little bit shorter. So now the ventricular myocardium isn't going to be getting the amount of oxygen at once in that small amount of time. It's going to end up having a higher demand and not enough supply. That can make it worse. So we want to slow that down a little bit, and we'll talk about drugs that we use that for. Another thing is you release norepinephrine onto the beta-1 receptors. What's that going to do? That's going to increase contractility. If you increase contractility, you increase your cardiac output. If you increase cardiac output, you increase blood pressure. But what else do you do when you cause the myocardium to have to contract so much? You consume large amounts of oxygen. Now the myocardium needs more blood flow, and it's not capable of being able to pump as much blood as you need to deliver the oxygen demand. Okay? So with these two situations, you increase the oxygen demand and you just don't have enough supply, and that stresses the heart. Another thing is, what else do these fibers do? Do you guys remember that there are also beta-1 receptors here on the renal arterioles, right? And what does that do? It also triggers the renin release, but it's also going to cause vasoconstriction, right? So if it causes vasoconstriction of the renal vessels as well as other vessels, that's going to do what? It's going to increase the total peripheral resistance. That's going to increase your blood pressure. But on the other aspect of it, it increases the afterload. And if you increase afterload, what do? You increase the stress on the heart. So let's give drugs that can block these different things, okay? What are some of the, and remember, this receptor here, I'm not talking about the JG cells. We already discussed those. Yes, the sympathetic nervous system can act on the beta-1 receptors on the JG cells of the kidney and cause renin release. I'm talking about the alpha-1 receptors on multiple different arterioles on the body, and whenever that vasoconstricts, it increases the total peripheral resistance, increasing afterload, okay? Now, if we give drugs like beta blockers, these are your class 1, okay? So these are going to be ones that you're going to give to the patients whenever you start them off, okay? So first line, you can try an ACE inhibitor or an ARB if they can't tolerate it, and a beta blocker. Big thing, can't forget this. You need to remember this. Let me put it here in orange. Never use beta blockers. They're contraindicated in decompensated heart failure. You never give these. Never give beta blockers when they're decompensated. They're not able to generate enough cardiac output. I'll explain why in just a second. What are some of these beta blockers that we use? So beta blockers that are commonly used are two main types. One is called metoprolol, and the other one is called carvedilol. Okay, so you got metoprolol and carvedilol. They work by having a negative chronotropic action, decreasing heart rate, negative inotropic action, decreasing contractility. And they also cause vasoconstriction to increase total peripheral resistance and afterload. Okay? Yes, this aspect of it will be good. And carvedilol is really the only one that has this mixed activity. Carvedilol has alpha and beta activity. Metoprolol is primarily beta activity. So that's important to remember. Metoprolol is more cardioselective. Carvedilol is a little bit less selective. Nonetheless, these drugs, you give them because they decrease afterload. They inhibit the renin-angiotensin-aldosterone axis as well. Remember, what else do they do? Just for the heck of it, so you guys have it. Remember, they also act on the kidney. And if you guys remember, they act on the JG cells. And when they act on the JG cells, that triggers the release of renin. So I don't want you guys to forget that as well. And if you guys remember, that triggers the whole renin-angiotensin-aldosterone axis. And again, if you guys want, these are beta-1 receptors, okay? But you inhibit the renin-angiotensin, you decrease the chronotropic action, decrease the inotropic action. This decreases the oxygen demand, slows down the heart rate, decreases the contractility to allow for the myocardium to relax a little bit, and you inhibit the afterload to continue to decrease the stress on the heart. These are the drugs that you use. Never in decompensated heart failure. Can't stress that enough. Other drugs that also affect the contractility of the heart are called digoxin, okay? This is a class 4. Really, you don't kind of go to this one until the patient has pretty much tried everything and nothing else is working. So a class 4 drug that you can try here is called digoxin, okay? So digoxin is pretty much your last line here that you're going to go with medications. One thing I want to add in here, because what digoxin is it actually increases contractility. It's a positive inotrope, but also a negative chronotrope. So you also use it in AFib. It also can block the AV node. Another drug that you can give, but specifically when a person is actually having a decompensated heart failure, is dobutamine. Why do I say that? If someone's heart is failing so much that they're not able to generate enough cardiac output, so significant that their blood pressure drops super, super low, what do they call that? Shock. Whenever their blood pressure is refractory to any type of thing and it's super, super low and it's just not able to do what it needs and compensate and try to increase the blood pressure the best it can and it's still low, that's called cardiogenic shock. Heart failure is a very common cause of cardiogenic shock, especially if they decompensate. So a drug that we can give to patients if they super decompensate and we need to increase their pressure is dobutamine, okay? So I just want you to remember, it's primarily for decompensated heart failure. Next thing that we'll talk about here is going to be your diuretics. These are technically considered to be class 2. So these are your class 2 drugs, okay? So diuretics, there's 2 types that I want you guys to remember. The main one that's utilized is your loop diuretics. The main one that I want you guys to remember is called furosemide, or commonly known as Lasix. Okay? The other one is going to be your thiazide diuretics. And these can be 2 types that I want you guys to remember. Hydrochlorothiazide and another one that's called metolazone. I specifically want you guys to remember this one. All right, so class 2, what I want you to remember about diuretics specifically is you use them whenever someone is basically not responding as well as you want to with an ACE inhibitor or an ARB and a beta blocker, or another situation where they're having a lot of fluid in their body. So they have peripheral edema, they have ascites, they have JVD, they have pulmonary edema. Then we want to pull all that excess fluid off. That's when we'll give these drugs. So again, you can give it as a class 2, but another thing I want you to remember is you can also use this drug whenever there is significant edema and you want to pull fluid, whether it's pulmonary edema or peripheral edema, okay? And if it's causing them to become symptomatic, you definitely want to give these drugs. How do they work? Very, very simply, all I want you to remember here, and it's really, really simple. The loop diuretics act on the loop. How do they do that? I want you to remember, I'm going to put D here for the DX, it inhibits a specific transporter called the sodium potassium 2 chloride cotransporter. Do you need to know that? Not really. What I want you to know is if it inhibits this, it doesn't allow for that sodium, potassium, and chloride to go out. So now sodium, potassium, and chloride build up here. What does sodium do? It brings with it water. So now I'm going to pull out maybe 25% of whatever they filter. So whatever gets filtered out of this, the glomerular filtration rate, whatever that is, 25% of that, I'm actually going to urinate out. And if I pull all of that fluid out, that's going to help me. So I'm going to increase their urine output. And by pulling off all that excess fluid, what do? That decreases their EDV. That decreases the preload. And that decreases the stress on the heart. Okay? The other one are going to be your thiazide diuretics. Your thiazide diuretics are going to inhibit this sodium chloride transporter in the distal convoluted tubule. If I inhibit sodium chloride reabsorption in the distal convoluted tubule, and at this point it might only be, 10 to 15% of the GFR, that's less than 25. But again, if I have some of this, I'm going to cause less sodium chloride to be reabsorbed. That's going to build up. What's going to follow with it? Water. And because of that, I'm going to get an increased urine output. That's going to cause a decrease in the total blood volume, decrease in the EDV, decrease in the preload, and decreasing the stress on the heart. Okay? As well as getting rid of all this excess fluid causing their symptoms like pulmonary or peripheral edema. Okay? Now, before I move on to these next two drugs, I want you to remember what's the primary one that you give. Well, it depends on the GFR, but pretty much people are getting loop diuretics. You start at 20 milligrams generally, and if you need to, you can increase, okay? But some tricks that can be taught is without having to increase the dosage of your loop diuretic, sometimes you can add another drug on called metolazone. So maybe I could do 20 milligrams of Lasix and add on metolazone, a thiazide diuretic, to pull off a little bit more fluid, okay, without having to increase the dosage of my diuretic. All right, so this next drug is called Hydralazine. Hydralazine is a pretty cool drug. It's well tolerated, especially in African American patients. And one of the beautiful things about this drug is it's also safe in pregnancy. So it's commonly used as a medication, one of the first-line medications in pregnancy. One of the downsides of it is that you have to take it 3 times a day, potentially. Now, hydralazine works by acting on the arterial smooth muscle, right? And what it does is it relaxes the arterial smooth muscle. Very quick, like little quick and dirty reason why. Hydralazine works on these smooth muscle cells by increasing nitric oxide concentration. Increase nitric oxide into the smooth muscle cell, it basically activates a particular enzyme called guanylyl cyclase. When you activate this enzyme, that converts what's called GTP into cyclic GMP. And through specific protein kinase regulation, this promotes the inhibition of calcium entry. And if calcium doesn't enter into the cell, it's not going to be able to contract. So what does that result in? Relaxation. So it promotes relaxation of the smooth muscle cells. So that's how hydralazine works, okay? Now, again, to make a little side note here, you don't usually use these drugs as first line. They're more your class 3, hydralazine, as well as the other drug over here, which is called isosorbide dinitrate. Now, these drugs right here, really the only time that you would use isosorbide dinitrate or hydralazine, we talked about hydralazine is commonly used in pregnancy. But usually in the treatment of heart failure, you would primarily use these drugs when ACE inhibitors aren't tolerated, then you go to ARBs. If ARBs aren't tolerated, then you go to these two drugs here, okay? You go to hydralazine and isosorbide dinitrate. Isosorbide dinitrate does the same exact thing. Overarching view is that this is also going to inhibit the vascular smooth muscle, but primarily on the venules. And the mechanism of action is the same. It's going to lead to increased nitric oxide production and actually help to promote relaxation of the smooth muscle. The overarching difference, though, is if you act on the arterial side and you promote relaxation of this muscle, what does that do? It helps to be able to decrease total peripheral resistance, right? Because you decrease the vasoconstrictive mechanisms. So the pressure proximal to this is going to drop. If you do that, you do two things. You drop pressure as well as decrease the afterload, which is that increased stress on the heart. That's a beautiful thing. With isosorbide dinitrate, what do? Well, you actually promote relaxation of this muscle, right? And what that's going to do is, if you relax this, there's not going to be as much blood. The force of blood is not going to be pushed through the venous system up to the right side of the heart. So there's a decreased right heart venous return. If there's a decrease in the right side of the heart venous return, what's going to happen to the end diastolic volume? You're going to drop the end diastolic volume. What does that do? That drops the preload on an already weak heart, which decreases the stress of that weakened heart. So these are the medications that you would go to in a class 3 type of situation, particularly whenever ACE inhibitors or ARBs have failed, or you want to use this in someone who's pregnant. And someone who has decompensated heart failure, the quick, easy way to remember the treatment, this is kind of a mnemonic that they commonly use, is LMNOP. So what does this mean? L stands for Lasix. That's a fancy word for saying furosemide. And what is furosemide? We already talked about this. He's a diuretic. So he's going to help to reduce a lot of the edema, particularly pulmonary edema, which can happen in patients with congestive heart failure, particularly left-sided. Another one is pain, right? So you got to control some of the pain that they might have, whether that be from the leg swelling, whether it be chest pain. You can treat them with morphine, maybe anywhere from 2 to 5 milligrams. The other thing is nitrates, which includes hydralazine, isosorbide dinitrate, to help to drop the actual afterload as well, and help to relieve some potential chest pain, ischemic chest pain. The other one is oxygen, and I can't stress how important this is. Whenever someone actually develops decompensated heart failure, fluid can back up into the lungs and make it very difficult to breathe. So one of the best things to do is to start the patient on maybe BiPAP or CPAP, and if necessary, or even just high flow nasal cannula, to get them as much oxygen that you possibly can in that respiratory struggle, especially when someone goes into what's called flash pulmonary edema. The last thing is position. Position them in a way that you're not fluid overloading them and making it difficult to breathe, which is in a supine position. You don't want them supine. Have them sit up, have them at an incline to allow for, unfortunately, the fluid to go down with gravity, which can cause some edema, but it's going to decrease the stress on the actual lungs, okay? All right, Ninja Nerds, so in this video, we talked about the treatment of heart failure. It was a brief overview of a lot of these medications, just overall mechanism of action, and particularly which ones you'll use in a sequential order in patients with heart failure. I hope this video made sense. If it did, guys, hit that like button, comment down in the comment section, and please subscribe. Also, down in the description box, we'll have links to our Facebook, Patreon, and even our Instagram account. Go check those out. As always, Ninja Nerds, until next time.